Thanks, everyone. Thank you, Kate, for the introduction. Today, we'll be presenting on under 5 mortality in fragile and conflict-affected states. And my disclaimer is that I'm not a policymaker or a university researcher with a specific focus on child mortality. I'm an epidemiologist working in humanitarian crises and doing operational research. And I've been involved with the evaluation of health programs like these, like child health programs, for the last 10 years or so. So I'm hoping to give you a specific perspective on the problem of child mortality in fragile states from the perspective of someone who evaluates a lot of these programs. So I've spent the last 10 years working as an epidemiologist with various organizations. One of them is primarily the International Rescue Committee, WHO and others, and I'm happy to talk with you about these experiences as well, those of you in the room. I'm putting a number of personal pictures up as well from various household surveys that we've done to evaluate programs. Just to give you an idea of the communities that we work with in fragile and conflict-affected states and what it looks like around the world. This is from the Democratic Republic of Congo in 2011, for instance, while we were doing a survey. So this is what we'll talk about today. Why are fragile and conflict-affected states important to understanding trends in global child mortality? And what are the determinants of child mortality in these states? What are some lessons learned and potential ways forward? How to address those determinants, how to measure progress and impact, and some ideas about new approaches that have been tried and that we're currently working on as a community. So, why are fragile and conflict-affected states so important to understanding global child mortality? First, let us try to understand the definition of a fragile and conflict-affected state. Typically, it's typified by insecurity, the breakdown in governance and rule of law, destruction of public infrastructure, including health facilities, but also other public goods. Massive population displacement can be a major factor. The collapse of the social contract between citizens and their states, and increasingly governments hostile towards displaced populations. And it might be some combination of those. It might be an acute conflict or acute disaster, natural disaster, or it might be a long simmering crisis in a country that undermines their ability to provide care for their citizens. So from the World Bank, we have these sobering statistics and discussion points. 2 billion people live in countries affected by fragility and conflict and violence. And by 2030, that proportion of the global poor, people considered poor, living in fragile states will reach 46%. And 95% of displaced people, including internally displaced people and refugees, live in developing countries. And they originate from the same 10 conflicts that have happened since 1991 and are consistently hosted. The displaced people are hosted by the same 15 countries, by around 15 countries, which are also in the developing world. So we see a lot of these issues are persistent and sort of stagnating. And so this is not an issue that will go away for countries that are hosting displaced people, as well as those that are home to conflict and fragility. So I made this map of one of the lists of fragile situations, as the World Bank refers to them, in 2018. Every year a list is developed to try to understand which countries fit this definition. And the World Bank definition goes into some detail about governance indicators and meeting a certain threshold for those indicators, as well as having United Nations peacekeeping missions in those countries. So it might be one or the other. And what I want to impress upon you here is that there's a lot of focus of countries in North Africa, Central Africa and West Africa, as well as East Africa. Some countries in the Middle East as well. But you can also see, I've circled Haiti as well, and Kosovo in Europe. Some countries which don't appear on this map in small island states in the Pacific Ocean as well. And we don't see too many countries other than Myanmar in Afghanistan in Asia. But, and we also don't see countries that have sort of subnational conflicts and fragile situations like Nigeria. But this is one of them. There's more than a few lists that we can use. So I do want to take you back to a place that I was a few weeks ago, which is a remote part of North Kivu in Democratic Republic of Congo. And we can start here when talking about the issues. So one of the projects, as Kate was explaining, I'm working on is non-communicable diseases in acute conflicts. And this was one of the settings where we're working on this project. But I was in a ward full of very healthy sleeping babies, which is always a good thing. And it was in a facility supported by the International Rescue Committee. And I had to think, what does it take to get here to this point where you have a healthy sleeping baby? How is this baby going to live out the first 5 years of his or her life? It takes a complete cycle of tasks. So you need to assure antenatal care, facility delivery at the facility, infant and young child feeding and nutrition, healthy, which is key to health, consistent access to immunization, safe water and sanitation at the community and household level, as well as at the health facility, ownership and use of a long-lasting insecticide-treated bed net, and then timely and consistent access to life-saving treatment for major childhood diseases at the very least. So that would be malaria, pneumonia, and diarrheal diseases. So that's a long list. In some places it's nearly impossible to complete all of those, but we try to work on different agencies and different parts of government are focused on each of these pillars in a way. And it takes a bit of luck as well given the context, but you can see the possibilities are really there for us. So these states are quite fragile, and humanitarian organizations like Médecins Sans Frontières, IRC, and UN organizations like UNICEF and the World Health Organization, they strive to advise or support ministries of health to implement programs, to fill in gaps, and to implement these basic life-saving programs. And it doesn't really matter what the health system looks like in these settings. This is Thailand, for instance, South Sudan, and Yemen in the far right. But what remains important are the core pillars of public health systems and prevention, ensuring demand for care at the community level, and then ensuring timely access to care. And then one important thing is quality of care. Quality of the care that's delivered. This is very difficult to do with a patchwork of actors that work in fragile states, but again, these are pillars to aspire to. So how do fragile and conflict-affected states fit into the trends of global trends of child mortality, which is where I'm trying to get to with the presentation. So here we have, as many of you know, a diagram of the Millennium Development Goals, which were a set of goals initiated by world leaders in the year 2000 to improve policies and governance and accountability to citizens within low-income countries, to improve mortality and a few key health areas as well as social and economic development. And these were billed as achievable objectives for countries to aspire to. And half of the goals, as you see here, relate to health. So placing health as very important to social and economic development. In 2015, there's been a new set of goals that have been set up called the Sustainable Development Goals, of which one relates to health. But it gives you an idea of the progress in this sort of agenda setting exercise. So we're going to focus today on Millennium Development Goal 4, which is to reduce the global under-5 mortality rate by 2/3 between 1990 and 2015, which we passed. And how would one do that? So the focus was on providing appropriate home care and timely treatment for newborns, addressing the integrated management of childhood illness for all children under 5, focusing on the existing expanded program for immunization, giving basic antigens, getting them to children, making sure they stick to the schedule and so forth, and then really supporting infant and young child feeding as an early determinant of health. So if we fast forward to 2015, we can produce these lovely graphs which show a global decrease in great news in under 5 mortality, infant mortality rates, and neonatal mortality rates. What I want to show you is, what I want you to focus on is that there was a very pronounced decrease in under 5 mortality rates, which is the blue line, from 91 deaths per 1,000 live births to 43 deaths per 1,000 live births. And what you can also see is the bottom line, which is the green line. There's a less pronounced decrease and not as dramatic in neonatal mortality rates. So we'd like to decompose this a little bit more. Deaths still remain high in fragile and conflict-affected states. Countries with the 10 highest under 5 mortality rates, which are listed here, have mortality rates with roughly 1 in 10 children dying before the age of 5. And that's 2 to 3 times the global average, which, as we know, averages don't tell the whole story. And so 44 countries did not meet the Millennium Development Goal of reducing under 5 mortality rate by 2/3. They might have had decreases, but they didn't meet that. And what that means is that of those 44 countries, 80% were actually fragile and conflict-affected states, which have had recent conflict, natural disaster, or both in some cases. So this is a further visualization of what we're talking about. So it's a graph showing all countries considered, countries of the world, in order of increasing under 5 mortality rate, deaths per 1,000 live births. And what we see here in the orange is the representation of fragile and conflict-affected states. And so these are what we see in terms of the projections that were done in 2013, that were shown in the Lancet. Without steady improvements in high-impact interventions, under 5 mortality rates will be the highest in countries like Chad, Central African Republic, Congo, Somalia, Nigeria, and so forth, Pakistan, Guinea. They're projected to be the highest by 2030. So we see a lot of the same. It's unchanging in a set of countries that require assistance. And importantly, if we look really closely at these countries, even countries that are not considered fragile states, like Ethiopia and Uganda, we see in-country inequity. What that means is that in Ethiopia, in Addis Ababa, the capital, the under 5 mortality rate might be 53 deaths per 1,000 live births. The national average is higher, but then in one remote part, a large part of the country that borders Sudan, the rate is 169 deaths per 1,000 live births. And the same can be said about Uganda. The national average is much lower than in the northern region, which is a border region of a conflict-affected state. And just for you to understand too, this is where we tend to find refugees and crisis settings within countries that are not considered typically fragile. And this is where organizations like MSF and IRC work typically. So, what are the determinants of child mortality in fragile states? Is it that armed conflict itself is a health risk because children die from injuries endured through the conflict, or is it endemic diseases? What is it that we should be intervening on? So first, we can look at how children what are the causes of death globally And this is driven by developing countries and in sub-Saharan Africa as well. This is the chart. We would see that the major causes on the left-hand side for children 1 to 59 months are pneumonia, diarrhea, malaria, and injuries as well. And for neonatal causes, you see that preterm complications and intrapartum related events are important, as is sepsis and meningitis. But malnutrition underlies 45% of these deaths. So it's a condition that happens in tandem with infectious disease, and we sort of can't ignore either side of the coin. But let's look specifically at fragile states. So this information comes from a survey that was done by the International Rescue Committee in the mid-2000s and repeated, a nationwide survey of the Democratic Republic of Congo that looked at what the under 5 mortality rates and the crude mortality rates were in a recall period of a certain time. And it also looked at the morbidity patterns underlying those deaths. And it's not quite verbal autopsy, but it is in terms of using familiar symptoms at the household level. They could isolate some probable causes of death. And what they found here, which you can read, is that it's the easily treatable diseases, which mirror the chart I just showed you, like fever and malaria, diarrhea, acute respiratory infections, and malnutrition, which underlie most of the deaths, more than 50% of the deaths, and that under 5 children accounted for 45% of the deaths, even though they make up a much smaller percentage of the sample. And that gives you the relative risk of dying being under 5 versus 5 and over. So these are very similar patterns that you see in these states. So let's talk now about some of the high level, the macro level, and then the community level drivers for under 5 mortality in fragile states. I've listed here a few. It's not exhaustive, but I think it gives you an idea of the enormity of the problem and sort of the levers where different skills might be important to work on these issues. So in broad strokes, governance issues and political instability in countries says a lot. The loss of the social contract as well is related to political instability and difficulties with governance. Second, related, is primary health services are inaccessible and understaffed. So this is an issue with many layers, and I'm sure some of you in the room work on so many different parts of health systems work, which is crucial. But at the end of the day, you want healthcare workers who are paid, who receive their salaries, who are motivated, and that's, to me, a very striking issue that we can't seem to get across in many contexts. And as we've been talking about, this chronically high burden of major communicable diseases, familiar ones, is very important to the discussion and will direct interventions that are appropriate. And a chronically high burden of neonatal death. And this, unfortunately, is something I won't touch on in this presentation because it's such a big area to cover. So first, let's start with this idea of political instability. What does it mean? And so some pediatric researchers use some of the World Bank's governance indicators to look at sort of a combined indicator for good governance, government effectiveness, which looked at perceptions from the public of government services, and then quality of policy formulation, various indicators, various components all put together into one indicator, which has its own faults, but I think is useful to look at outside of health. And these pediatric researchers compared the neonatal mortality rates in countries across the world to government effectiveness. And what they found was it's inversely related, essentially that countries with the highest neonatal mortality rates have quite low government effectiveness indicators. And why is that? It could be that political legitimacy is undermined by the inability to deliver services to that population. So this is just a broad way of thinking about things. And this brings us to the relationship with primary healthcare services. So health services, health systems are really characterized by fragmentation, different actors doing different things, and a patchwork of actors, NGOs, civil organizations, and of course the Ministry of Health working together to put things together in a cohesive way. And I included a small quote from a very esteemed researcher in this area, Enrico Pavignani, who said that health systems can be driven by survival, power, and profit, meaning that they're trying to survive, patch together services for communities, but there is, in that vacuum of services, when there's no services present, there are entities that provide care for profit, and out-of-pocket expenses become very high because in some cases healthcare workers have not been paid. They're unable to put those pieces together. So these all sort of work synergistically, the health workforce being depleted, out-of-pocket costs being high, and so forth. So it's incredibly tricky to work on all of those levels. And then as well, your consequences that you have, in some cases, poor service delivery and questionable value of some of the healthcare services that are offered without a lot of supervision, without the required supplies for a nurse to be able to administer an IV properly, for instance. And of interest to this room, poor data-to-based decision-making. I do want to say as well that last box, chronic emergencies and chronic crises, different healthcare structures emerge that fill the vacuum, and they're long-running, and it's very hard to understand unless you're really engaged with working with the many different actors that are there. So this by no means covers all the different possibilities. So there's many areas where we need to work on here, the health workforce being a big one. And so we know now that under 5 mortality is not due to direct deaths, due to conflict for the most part, but healthcare facilities may simply be scarce or inaccessible to the most underserved communities where mortality rates are the highest. And this is from a survey we did on the border of Ethiopia and Sudan, showing the kind of terrain that's there. And reasons why you might have a chronically high burden of neonatal death. And I found this quote really interesting from a paper from the Vietnam War, which talked about the simple fact that type of war had a lot of bombing, and it prevented access to perinatal health services, and mothers had to deliver without a skilled attendant simply because they couldn't reach those services. And this happens in many places where we work, but it also can be that in a chronic conflict-affected area, it's a remote area that has not a lot of services and communities are underserved. So now I'd like to just talk about some lessons learned and ways forward from evaluating some of these programs. I like this picture because it reminds me of trying to find your way around by getting to the top of the highest tree around. You could probably get a cell phone signal up there too. So, yeah. So, this is the list of crucial services for children in fragile and conflict-affected states. There's a lot. I'm only able to cover a few in this presentation, and I really want to impress upon you that, for instance, water, sanitation, and hygiene, it's the cornerstone of prevention. In conflict-affected states, one analysis that I looked at had only 2 of the 20 listed as being able to meet their targets for the Sustainable Development Goals for improved water and sanitation by 2030. So these are huge industrial and as well as behavioral issues to work out. It's not just confined to the things that I'm going to talk about now. So some good news is that under 5 mortality rates and neonatal mortality rates have improved in some fragile and conflict-affected states, and there's some great analysis on why that has happened. And in general, as far as I can decipher, in all cases, there's been a combination of very high-impact interventions being scaled up quickly, but also looking at other sectors that are needed to empower changes, education and so forth. In Niger, it's a country continuously affected by famine and malnutrition and some conflict. And this analysis looked at the decrease in under 5 mortality rate in particular as being related to a strategy of providing peripheral health centers and staffing and training, ensuring staffing and training of human resources in those centers was clear and provided well over this time period. And also ensuring that commodities like drugs and equipment was insured as well, creating those big systems to make sure the farthest health facilities got those commodities in time and didn't experience stockouts. They removed user fees and backed this up with some debt relief policies as well that were made. So, you know, and they also focused on mass campaigns to catch up populations to have bed nets and get measles vaccination coverage and get to a certain baseline level. And finally, they focused on malnutrition. Malnutrition being very important. This being a country that's very much affected by famine and nutritional hazards at different points. And they continued that through and sort of mainstreamed it so health facilities could look at malnutrition care as well. So again, I want to, before thinking about new ideas or reinforcing existing ideas, I want to look at, again, why children are dying globally. And we do see, as we were saying, pneumonia is a very big issue, and it's often called, I think there's even a WHO document that says it's a forgotten health crisis, pneumonia and acute respiratory infections. So with that in mind, prevention, let's think big about vaccines which are not considered completely routine yet. So the pneumococcal and rotavirus vaccines, for instance, each covering pneumonia, causes of pneumonia, and rotavirus covering many rotavirus. The coverage is low in countries that are eligible for assistance from Gavi, the global vaccine body, and low means 41% in developing countries that can access those vaccines versus 80% in high-income countries. Well, this is important because pneumonia is such a big cause of death, and it would be, in terms of prevention, it's one of the things that can be done. And you can see here the gap between the green line and basically all the other lines, which is striking. But I think there are efforts to update policies for fragile states to ensure that displaced people who are currently not targeted by these policies can be included in country budgets and so forth to address their needs for vaccines, including hopefully pneumococcal vaccine. And just to impress upon you as well that vaccination coverage has really gone down in a lot of countries affected by conflict, which you see here between 2010 and 2016. It's dynamic, and this is for the DTP3. As well, let's think about treatment, thinking about equity and rigor in many of the common community-based and village-based treatment programs for malaria, pneumonia, and diarrhea. One important one is integrated community case management, and that's where community members are trained to provide health services, including the treatment and screening for a number of childhood diseases, a very limited number. And this is really aided by their proximity to their communities. They live in the community, they're trained to do this, they're immediately accessible. You don't have to go to the health facility for most childhood illnesses, but they're connected to the health facility. And they're given the proper antibiotics, oral rehydration salt and zinc, and antimalarials to treat children under 5, and they can refer for complicated cases. So how does this work in conflict-affected states? Well, some work done by some colleagues at the IRC. This is from South Sudan. It's looking at a child health ICCM community case management program in South Sudan during a period of conflict. They were able to show that, that arrow should be right here, right in the middle of where this dip is. They were able to show that during this period of acute conflict, reaching this conflict-affected area, very remote, they were able to reach the levels of utilization for the community health worker program soon after that acute shock. So it provided care in the community while these communities couldn't access care from health facilities, and it proved to be somewhat resilient. So that's good news. And just also to show, there's evidence to show that this drug protocol that the community health workers use works, and that community health workers can diagnose and treat these diseases among kids, even if they're volunteers or usually a farmer or teacher in their day-to-day life. But these are all the obstacles for operationalizing this idea, which you can, I'm sure, understand. It requires supervision. People have very low literacy. There's an underutilization of community health workers. Communities might not want treatment from their neighbor. I don't know. I mean, supply chain issues, these are all issues common to health systems. And so how does that translate into child life saved? We have to work on all of these pillars as well. So in my remaining minutes, I'm going to talk briefly about a program that we've learned a lot from, which is IRC's implementation with the Ministry of Health of integrated community case management in Kono district in Sierra Leone. And it's discussed in this paper, which we can provide for you as well. Just the brief background, in Sierra Leone in 2015, the under 5 mortality rates ranked only under some other conflict-affected and fragile countries of the world, in the top 5. And after the war in Sierra Leone, there were 1,000 plus healthcare facilities which were rehabilitated, and a free healthcare initiative was initiated to provide care at no cost for under 5 children and pregnant and lactating women. But the high under 5 mortality rate was relatively unaffected because there were scarce human resources to fulfill this goal. So IRC and other agencies introduced integrated community case management at a district level, a large level, in 2010. And with the Center for Disease Control in the U.S. and Prevention in the U.S., we evaluated the impact of this program on child health using large-scale household surveys of thousands of households, as you can see. And we compared indicators of child mortality, coverage of appropriate treatments, and timely access to care, quality of care, and recognition at the community level of this resource in the community. So this is briefly how it's done. You conduct interviews with mothers and to find out about deaths in their household over a recall period, as well as the health of their children over the last 2 weeks and what was done to receive treatment, the care seeking and what they received. So even when you go as far as to look at the drugs that were received as well, can you identify what drugs were received to assure that the appropriate treatment, to measure the appropriate treatment that was given? And briefly, what we see here is that the mortality rates did decrease non-significantly by a certain percentage among children who are the target population of this intervention. And the study was, the evaluation and the survey, the sample size was powered to detect a difference equal or above 28%. So this might have been why we didn't have the sample big enough to look at this properly. But at the same time, I want to show you it increased among the over 5 group as well. Significantly, and it's in this context that we started asking questions about what the program's doing and so forth. Interestingly, when we look at the coverage of appropriate treatment for the conditions, the first column here looks at the treatment from the community health worker or health facility. The care-seeking behavior from those entities. And the second column looks at the treatment received, whether it was appropriate from either of those, the facility or the community health worker. And the third column looks at the treatment just from the community health worker. Was it appropriate? And what we see in general is that the proportion of sick children with fever and diarrhea who got appropriate treatment in 2013 increased over the values in 2010. And it's largely driven by community health workers providing that service and also, referring cases to the health facility and so forth. Some good news, but lots of areas to work on. And really what I want to show you here is really the use of epidemiology data to improve programs. I mean, we collect a lot of data, we evaluate a lot of programs, and we don't, in lots of cases, use that data well enough. And I think some ICCM evaluations have shown that by the time you get to the end of the program, well, we didn't have an impact on mortality because we found out that the program wasn't targeting what it needed to target, or this part of the system wasn't working. There were insufficient inputs. And what we were able to do for this fragile state program in Sierra Leone was look at, from the very beginning, all the supply chain adaptations that are needed to provide a system that works in a very fragile state, and the rigorous supervision and training that's needed. And some of the findings from the first survey that was done really were interrogated and used to improve the program halfway through, tripling the drug supply to community health workers because we found out that didn't work, looking at stockout monitoring as well, and correcting the over-treatment of cough, for instance. So really looking at in fine detail, which really helps to improve programs using data. And lastly, one new thing that IRC has been doing is testing looking at the underlying burden of malnutrition through these community health worker programs, and looking at, in the areas which have very high severe acute malnutrition, can community health workers who have much lower literacy than other countries, for instance, can they also deliver care for acute malnutrition? And that's been interesting. Those results are yet to be released, but that's been a useful sort of exercise in looking at how to adapt these concepts that have been devised for health facilities in low resource settings for very remote areas where your health worker is going to be a lesser trained person with low literacy who needs adapted tools but is very close to the community and understands the community much better. And so what I want to end this by saying is that in conflict and fragile and conflict affected states, we know where we need to act. We know what the causes of death are as well. We know that it's possible in the bottom left graph, and we know some models that could work. So I hope that inspires you a bit to think through the motivation for good results in these settings. Thanks very much.